No, no, I don't want to raise my hand. No, I don't want to do that either. Right. Hello, everyone.
Hi.
Hi, Ben.
I'm trying to work out. I can see. I can't see any of you actually, but there, Louis. At least there's a friend.
Hi.
So it was a bit strange just talking to your computer screen and not knowing whether there's actually anyone out there or not. So okay, so I can see there's a number of participants still joining. So maybe we'll give it a moment. If I look at participants, then this box everything else off. Looks quite okay. Sorry, I'm just. Right. Okay. So hopefully everyone can see me, and I will again try and share my screen. I think everyone's there. Andy, are you there?
Yes.
Good. Okay, great. Well, welcome everyone. A few names we know in the participants. We've got about 14 of us here, so that should be okay for a bit of a discussion. Okay, so I'm going to try and share my screen. Sorry, I've got two screens here. This is why I'm not looking necessarily at the camera. Okay, now let's try one more time and share the screen. Okay, so feel free to chip in if you, well, if you can't see what you think you should be able to see on the screen, or if you have any questions or things you want to clarify.
Hello.
So, hello. Who's that? No. Okay. So this session is we're going to talk about a little bit about this project. Well, there's a couple of projects that are through the Improving Population Health theme that are really about how we decide on how much money and resource and staff, particularly within the NHS, but also social care, we allocate to different places, like different places across the country, or smaller neighbourhoods within an area like Liverpool or Lancashire. But these are really important decisions that are made nationally, but also by local healthcare organisations that have potentially a large effect on health and health inequalities. And we've got, so the amount of money that's basically allocated to different communities influences the access to healthcare within those communities, the number of doctors that are provided, number of nurses, and getting that right for the level of need in those places both affects healthcare and access quality, but also outcomes. And we've shown previously that changes in how those resources are distributed has quite a big effect on health inequalities. So we've got two projects that are kind of linked. We have a national research project where we're working with the team in the Department of Health, how they come up with the formula to allocate NHS money to local places, so to sort of local CCGs, clinical commissioning groups, and we're working with them to develop that formula so it better takes into account levels of unmet need. And we have a local project where we're working with Merseycare, which has just started, so that's an opportunity to influence that project. And that's looking at developing a kind of local formula to decide on the need within different neighborhoods. So that could be like primary care network neighborhoods or groups of GP practices. And then for them to use that in deciding on staffing levels in different places for their community teams. And so that better matches levels of need. Okay, so I'm just gonna give you a bit of an outline of how these national decisions are making, because it's one of these areas that there's very members of the public and even sort of professionals don't necessarily know that much about how these decisions are made. And we've got a little exercise on some of the potentially difficult decisions that are made in developing those formulae. And then we're going to talk a little bit about the project in Merseyside, and then a bit of discussion about really to get some insights from yourselves about what people think we should be focusing on in that project. So how does the NHS decide on how much money different places get? So how much money Liverpool gets compared to Surrey, or out of the total NHS budget. So the NHS in England spends about £80 billion a year, and that's split across different service areas. So specialist services get about 13% of that, general practice gets about 13%, kind of community health services, so that's things like district nurses, community health teams get about 10%, about 4% goes to public health, so that then goes to local authorities, about 7% goes on mental health services, and then about 33% goes on hospital care. So quite a big chunk is spent on hospitals. Some people might argue that it's quite a small amount on public health and prevention, and quite a small amount on primary care, and that maybe it'd be more efficient if we shifted more to prevention and primary care. So this map just shows how much money different places get per head of population. So the darker places get more money per person from the NHS than the places with sort of lighter colours. So there's big differences between how much money different places get per head of population. So the NHS in Liverpool will get about 50% more than the NHS in Oxford, for example, per head of population. And that's actually similar between somewhere like Winchester and Liverpool. So for every pound that per head you're getting in Liverpool, or every pound per head that Winchester gets to spend on NHS services, Liverpool gets about 50% more. So, places like Liverpool do tend to get, and places in the north do tend to get more NHS funding per head of population than other places. Generally, more affluent places tend to get less per head of population. So, and that's because the NHS tries to fund services according to the level of need, and levels of need are assessed as being greater in places like Liverpool compared to places like Winchester. So, and they do that by having a formula that takes into account different population factors to determine what the level of need is and therefore the amount of funding. Generally, that takes into account a few different factors, which is shown on the right here. So places that have older populations may need to have greater need for healthcare services, tend to get more. Places that are more deprived also tend to get more. Places with a higher burden of disease, so more people with health conditions get more. And the formula also tries to take into account how much it costs in different places to provide health services. So like wages might be higher in some places compared to others. So, clearly one of the reasons why, and one of the things that the NHS aims to try and take into account is levels of health inequalities. So this on the left is Winchester, which has a life expectancy of 84 years, compared to Liverpool, which has a life expectancy of about 78 years. So that's one of the reasons why the NHS aims to allocate more resources to places like Liverpool, because there's poorer health in those areas, and that means that they tend to use more health services. The other thing is the amount of disease in different places. So places like Liverpool, will tend to have more people with health problems, whilst places like Winchester that are more affluent will have fewer people with health problems. One of the things that they try and take an account of in the formula is not just how many people that we already know have health problems in different places, but also trying to take into account people that might have undiagnosed health problems. So what sometimes is called unmet need. So one of the things we don't really know is difficult to work out is how much unmet need there is in different populations. So at the moment, the NHS tries to come up with an estimate of how much, so how many people there are in each place with levels of unmet need, and try and put more money into places that have potentially more larger people with undiagnosed health conditions. That's one of our projects, is to try and estimate that level of unmet need better. So in each of there are several different formula that are used by the NHS for different areas of service. So the main CCG formula is allocating resources for kind of hospital services, but also prescribing. And then there's a primary care formula that allocates resources for primary care. And then there's another specialized formula that allocates resources to different places for specialized services. And each of those, a certain proportion of them there's a special adjustment to try and take into account these two different factors. So health inequalities, so the different levels of health outcomes between places, so allocating more money to places with poorer health, and unmet need, so the allocating a bit more money to places where we think there are more people in the population who have undiagnosed health problems that are not getting the care that they need. And the proportion of that funding that is adjusted for those things differs. Is greatest for primary care, and they adjust it less for specialized care, because the thoughts are that primary care is where you need extra funding to pick up undiagnosed conditions, and that's the best place for addressing health inequalities. But there's been quite a big debate as to how much we should adjust that funding for for health inequalities. So how much should we take into account that people at younger ages in more deprived areas are developing these health conditions at younger ages, and that they have those higher sort of premature mortality in those places? Or how much we should just take into account levels of unmet need or the access that people have to services. And some people have argued that the NHS at the moment prioritizes deprived areas too much, and actually that there are other areas that are less deprived but have much older populations, and that those places have been kind of underfunded in the current system, and that leads to longer waiting times for services, and whilst the additional resources that have gone into more deprived areas over time have benefited those areas in terms of access to healthcare, but that has had a disadvantaged effect on other areas where there tend to be older populations, where even though those areas are generally more affluent and people have better health outcomes in those areas, that's why they're living longer, but they potentially have more people who need to use health services because they're older. So there's been this argument about how much we should adjust for health inequalities and how much we should just focus on where everyone has equal access. So, are there any questions or thoughts on that? On the kind of national formula, or then we'll move into doing a little trying out this little exercise that we've got to try out some of those difficult decisions that we're having to try and make with this formula.
Ben, can I ask a question?
Yes, please.
Yeah, sorry, I'm just looking at your chat. Fiona's asking a question about the resource allocation formula. How often is that updated? And I mean, I remember working with you with a group of advisors, probably last year, when they were supporting, giving their PPI input into the development of the proposal. I've just wondered about the allocation formula. How often is it changed?
So the allocation formula is kind of updated every few years.
Right.
Sometimes the data that's used is updated every year, but then they redefine the formula every few years. It gets kind of revised, and it's all the decisions made by this committee called the Advisory Committee on Resource Allocation at the Department of Health. But the work that we've started doing on the national formula, we will be running some public engagement sessions with that, probably the beginning of next year, to get more input into how that is used.
Thank you.
Good. Sorry, I'm just trying to keep a track on the time. How long does this session go on for? And how far behind are we?
You've got, it looks like you've got 20 minutes. Oh no, 20 minutes.
Okay, so we're probably a bit behind on this. But so one of the things is how we how much we take into account kind of access to services, and how much we take into account inequalities. And so this exercise, we'll see how this works. But if we've got two hypothetical areas, so one in a kind of rich part of the country and one in a poorer part of the country, so you can think of this as two different CCGs. So in the poorer area, the prevalence of depression has been historically a lot higher because of high unemployment, poor housing, and a range of social problems, something that we are all quite familiar with. And then you have the investment in services for depression, so psychological therapy services, historically has been higher in that poorer area, and that's helped reduce levels of depression a bit, but they're still a lot higher in the poorer CCG. So they're still twice as high as they are as in the sort of wealthier area. But this historical investment prioritizing poor areas has led to much lower waiting times in the poorer CCG than in the richer CCG. So the lower investment in the richer areas has led to longer waiting times. So we basically have a situation, and this is a plausible situation where you actually have kind of better access in the more deprived areas than in a kind of wealthier area, but you still have inequalities that mean that people in the poorer part area are still more adversely affected by a particular health condition like depression. So, and the government's made sort of additional funding available in this hypothetical situation, £1 million, and you have to decide on how you would share it out between those two CCGs to invest in additional capacity for psychological therapies. And the more you invest, you reduce waiting times, but you also reduce the prevalence of depression. So you start off with a situation where depression is higher, 20% of the population are suffering from depression than in the richer CCG, so CCG1 and CCG2. But waiting times are lower in the poorer area, but higher in the richer area. And then you have to decide on how you're going to share this new investment between those areas. And Andy, if you could post that link in the chat, then which you should have access to. Then people can. There's an online tool that you can use to distribute that money on how you think it should be shared out, and you should be able to see then in this scenario as to how much the inequalities in depression change between the two CCGs and how much waiting times change. So this is potentially a sort of real conundrum that we are faced with in deciding on these resource allocation questions. So you could say we'll allocate 80% of that to the poorest CCG, so that's CCG number 1. And doing that, you would basically remove inequalities in depression. But you would increase inequalities in access to services, because you lead to much higher waiting times in the wealthier CCG. The CCG that's serving a kind of wealthier population. So you reduce inequalities in outcomes, but you increase inequalities in access. Similarly, you could do the other way. You could say, well, I think everywhere should have the same access. So we should aim to just make sure everywhere has sort of similar waiting times for the service. Try and reduce them as much as you can, but make them as equal as possible. So you'd allocate more of your money then to the wealthier CCG because that had the longest waiting times. But in doing that, you increase inequalities in depression. So the question is, which ones? Which would you go for? I can't actually see the chat, which is, have you managed to post that link, Andy? Not that one. Oh, well, maybe that one as well. But the link
Bennett's in the poll. There's a poll on your right-hand side on the bar chart icon. If you click on that, it's giving us an option to vote on the percentage of resource we'd allocate to the CCG.
Yeah, it was the link to the app was what we meant to post. So that was the first thing. Let me just find it.
Is that just being posted by James now? Is that the link in the chat?
Yeah, I think so apologies, I probably said it wrong.
Isn't it the one I posted?
Louis, yeah, hopefully. See the screen. Can't see the chat, can't see anything. Ah. Okay.
I can't click on that poll. I can't click on that link in the chat.
No. Okay, let me just try it. History. Okay, where is it? Okay, right. Let me just try and. So the app should. I don't know whether that does that go through to you?
Ben, I posted it in the other chat as well. The chat on the right-hand screen, right-hand bit of the screen. So it's in for people that aren't aware, there's two chats going on. Unfortunately, there's the Zoom platform chat, and then the chat that's linked to this particular platform that's on your right-hand side, that has the chat icon, the participant icon, and the bar chart icon. I've just posted it in that chat there as well, so it's in both chats currently.
I can't see where you posted it, Paula.
You should be able to access this, something that looks like this, but
it doesn't seem to be live or working, the link.
Does it not come through at all?
Maybe it doesn't provide a direct link, so maybe if you copy and paste into the browser, maybe it will work.
Yes, that works. If you copy and paste.
Make a decision.
So ideally, anyway.
Fiona, are you copying and pasting what James has sent through, or I can't see what I can't see Paula's chat.
The one Ben's posted, I copied and pasted into a separate window on Google on my screen, and it's come through.
Okay.
Yeah, sorry.
I don't know why I'm not seeing most of the chat. I can only see what James posted. Maybe I'm in the wrong chat.
Well, anyway, it's not quite working as planned, as we may have preempted. But the point is, I suppose, is how much should we prioritize access or outcomes, particularly if those are in many cases it'll be the places that have the worst health that will also have the worst access to healthcare, but that's not always the case. And
I have a point, a question, and I'm sorry, my can't hear everything I'm saying. Let me know. But for certain services, obviously, you reach a point where the delay in accessing a service is so long that you may already be, for example, dead. So if it's ambulance services, you're delaying the response time beyond the point where actually the ambulances is going to be. It is the case potentially for mental your point, the service actually isn't any use to you because far worse has happened.
Yeah. I mean, so one of the things that is often discussed in coming up with these different formulae is that in places where there's lots of sort of social and economic problems, that the NHS can't solve those problems. That what you need to do is solve the causes of those problems. So maybe it'd be better to invest more in employment support or housing or other things in those places, rather than putting more money into kind of treatment. And therefore, we shouldn't necessarily prioritize that in the NHS funding. We should prioritize those places more in things like the education budget. Or so there is a poll there for you to vote on what percentage you would allocate to the more affluent CCG. So, which you should be able to see on my screen. Hopefully, I'm sharing the screen still. Yeah, which I am. I can't actually see how many people have voted, but basically, so some people have gone for prioritizing the places with longer waiting times more, and others have gone for prioritizing places with worse health outcomes. So if you're allocating 70% to the wealthier DCG, you're reducing waiting times and making them more equal. But if you're allocating only 30% to the more affluent area, then you're prioritizing the places with worse health outcomes, but potentially increasing differences in waiting times. So I think we're going to run out of time. So, but the project that we've got locally then is then using that using the data that we have available on different factors to decide on how Merseycare allocates teams to different places in terms of their sort of staffing levels. And we have lots of really good linked data across the whole region, and this just shows differences in mental health problems and on the left, and respiratory problems, so chronic obstructive pulmonary disease between different places. And there's huge differences between places. So one of the questions is really what kind of things should we utilize? What kind of information should we use to decide on how they allocate those resources to different places? So that could be things related to the amount of disease. It could be things related to the sort of social factors, things related to demographics, so age, gender, ethnicity. That some of those things we know are related to people's access to healthcare. Or it can be related to things to do with the services. So how much investment has there been in the past in that neighbourhood? Should we take into account things like waiting times for services, or maybe we should give more money to places where that are providing better services as an incentive. Some of the schemes that we have, like for GP practices, you get more money if if they improve their quality better. So in the final few minutes, it would be useful for anyone to, if anyone has any thoughts on what kind of factors do you think we should be looking at in that work, and are there things that are there other parts of the Northwest Coast where this would be useful? This kind of work would be useful for local healthcare organisations.
Ben, can I just, it's Fiona Ward here, ARC staff. Can I just ask Ben where those factors come from, the ones in the blue? Are they standard factors, or are they factors that you've come up with?
They're basically things that I've come up with, but at the moment, most of that is taken, most of those are taken into account in national formulae in some way or other, in deciding how the NHS allocates its money. But we don't necessarily have to do the same things that are done nationally.
Thank you.
But yeah, so does anyone else have any thoughts on the extent to which we should take into account just access, or should we give an extra weight to try and reduce an extra emphasis on trying to reduce health inequalities?
Surprise you that I allocated all the. I'm trying to be a little contentious.
You allocated all the money to which one? Yeah.
To the affluent area.
To the affluent area, right? Yeah.
And I did that because I believe quite strongly that you can't expect people to wait for this particular service for the length of time that they are waiting. That actually it is in effect no service to wait 6 months for treatment for depression.
Yeah, I think that's a really valid point. And the other thing is that it's going to be the poor people. It's going to be people in poverty who are living in an affluent area are likely to be more at risk of depression. So they will also be the people that that are having to wait longer. So yeah, in those places for that service, if there's a really long waiting time. So it's not necessarily, at the moment the NHS kind of allocates resources based on the kind of averages for different places, but that could mean that disadvantaged groups that live in more affluent areas are particularly disadvantaged because they may end up with under-resourced services in those places.
Hi Ben, this is Nick Wilson from the NHSA. Can you hear me okay?
I can hear you, yes.
Hi, good morning. I was really interested to see and hear what you were talking about, and unfortunately I struggled with the platform to be able to vote, but I completely agree with what Andy has just said in terms of, sort of a 6-month waiting time is tantamount to no service, and I too would have actually voted in that way as well, if that's useful.
Hi, everyone who's still here and can hear me. I think the session has automatically closed in the Attendify platform, but it's still running in the Zoom pop-out.
Okay, sorry, this is Nick Wilson here from the NHSA. I've had real problems with the platform and being able to engage in the last session. So you're saying that I can continue speaking with those people, or I go to my next session?
I'll go to the next session because it's ended in the platform itself. So we're just kind of trapped in this Zoom holding room. I've been having issues too.
Okay, thanks for your help.
Okay, sure.
Bye.